medicinal cannabis expert reference group, the domestic violence service team, UNESCO, Ireland, and on. His bio goes on for a couple of paragraphs. Professor Smith will be speaking to us today about the ethics of decision-making during the pandemic. So, Professor Smith, thanks for being here.
Thank you very much, Mark. I'm delighted to be invited to deliver this lecture and reflections on the topic of we've chosen the ethical decision-making during a pandemic. And I suppose all of us were involved in some way with this. And therefore, it's quite important that we have some reflection on how ethical decisions were made during the pandemic. My slides don't seem to be moving, Deirdre. Oh, yeah, there we are. You're all familiar with this slide. I'm sure you've seen it so often. So what I want to look at really are what are the ethical principles involved, and then some of the other major ethical issues that have started to arise, particularly around the area of vaccines, vaccinations, etc., compulsory or not, a quick reflection on challenge studies, and then a reflection on what actually happened and how healthcare was delivered or wasn't delivered, and its impact on patients, obviously, and on healthcare systems, and then very importantly on training, how that has affected training of healthcare practitioners. I start with a very small quote.
Sir, before you go on, we can't really see your slides. Would you mind trying to reshare them?
Yeah, let me go out of this. Sorry, I'm sorry about this.
Will I try from here, Professor?
Hang on, I'll just give me a moment.
Sure.
Can you see them now?
Perfect, thank you.
Perfect, right, we'll continue. Sorry about that, everybody. I start with a very small quote. Many patients have a dry and unproductive cough and a hoarse voice. Some had a fever, but not all of them had fever. This is actually a quote from Hippocrates in the year 400 BC. But it's a quote that most of us could align ourselves with today when dealing with COVID-19. As I've said, significant ethical issues arise during the whole COVID crisis, and rationing became one of the major issues within it. In Ireland, the National Public Health Emergency Team, NEFIT, was set up. It was established in the beginning of January of 2020, and it's still in action. A number of subcommittees were set up, and one of the subcommittees I was on was the Pandemic Ethics Advisory Group. And what we were asked to do was develop the ethical guidelines, particularly for access to ICU units or intensive care treatment. So that became quite an important point for us. What we then decided was what ethical principles were we going to use? And most of you would be familiar with principalism, developed by Beecham and Childers. They talk about these four core principles: respect for autonomy, non-malevolence, beneficence, and justice. An important component to that really was the balancing between respect for autonomy, beneficence, etc., to try and balance them out. However, we did notice that there can be clashes between respect for a patient's autonomy and, in this particular case, of allocation of resources with justice as well. So we were very aware of those possibilities that were there. in our reflection, we found that where intensive care resources become limited, it's ethically necessary, justifiable, and proportionate to have mechanisms or decision tools in place to enable healthcare professionals to triage and prioritize access to these resources. So that was an underlying theme which we started with. So we decided to start with an ethical framework for decision making. And this framework really had a number of core principles. The minimizing of harm. Really, in public health ethics, the obligation is to protect the public from serious harm. But it's actually a very broad concept. It can be physical, psychological, etc. And we know that in the treatment of society, and particularly in patients, there were restrictions on our liberty. We had to self-isolate. Access to services were very limited. And in Dublin, in the first lockdown, we were restricted to a 2-kilometer limit from our homes. So these became very important areas of minimizing harm. Proportionality requires that the restrictions to individual liberty and measures taken to protect the public from serious harm should not exceed what is considered necessary to address the actual level of risk or critical need of the community. So that, you know, were the lockdowns, etc., were they actually proportionate to us in a way? Solidarity really was an attempt to try and say that we need to get away from territorialism, where each sort of health system or each hospital tries to prioritize itself and to the detriment of others. And that also became quite an important international one. In certain jurisdictions around the world, it was quite noticeable that private patients got access to the vaccines far quicker than public patients. And in some jurisdictions, the politicians got access to the vaccines before anybody else. The duty to provide care is a very important component in healthcare care ethics and professionalism. However, professionals also need to weigh the demands of their roles against other competing obligations to their own health and to the health of their families and to those they encounter. Reciprocity requires that society supports those who face disproportionate burdens in protecting the public good and take steps to minimize the risks and burdens as far as possible. Privacy, individuals have a right to privacy and confidentiality with respect to their information. However, we know that during the pandemic, privacy rights were most probably not absolute, and to some degree, a lot of commentators would say quite seriously violated. We then had some procedural guidelines which we looked at, and this was the reasonableness. All decisions should be based on best medical evidence available and should be reasonable. There should be openness and transparency on how decisions are made and why they are made. And this should be, and the public should be made aware of these. Inclusiveness, really, that you need to consult as many people as possible from different groups, etc., to ensure that your decisions are being adequately addressed and looked at. Accountability. This requires that we are accountable for the decisions that we made, and mechanisms are put in place to look at these and how they were responded to. So with that, we looked at allocation of resources. Decisions had to be made regarding who should be prioritized to receive an intervention. These decisions should be based on the underlying rationale of maximizing the benefit that can be gained and give due attention to fair distribution of benefits and burdens. Patients with COVID-19 as a cohort should not be given preferential treatment over other patient cohorts requiring acute care. Neither should they be treated less favorably. So we started with that basic premise in our work. We were also familiar with the different guidelines that were emerging sort of in the beginning of 2000 up until about April, May. There was a plethora of guidelines coming from different health systems. And we were aware of these and looked at these. But what we saw was a certain sense of interconnectedness. And therefore, when you were assessing whether a patient would be admitted to intensive care, you had to look at the type and severity of the patient's illness, the presence of any comorbidities, and how frail the patient was, the impairment of other organs and systems, and whether the impairment could be alleviated with intensive care treatment, how long the patient is likely to require intensive care treatment, consideration of the patient's capacity to withstand the physical impact of intensive treatment, particularly mechanical ventilation. and also the long-term functional status should they actually survive. And I suppose a lot of us are now getting more and more familiar with what we call long-term COVID. The patient's own informed views on whether to undergo intensive therapies, such as mechanical ventilation. So that was most probably a very important one for us as well, that you needed, if possible, to discuss it with the patient, all the implications of intensive care treatment and particularly mechanical ventilation, and help them to try and make an informed decision while taking the other factors into account as well. Factors such as frailty or existence of comorbidities were only to be considered relevant in triage decisions insofar as they had an impact on the patient's potential to benefit from an intensive care admission and remain survival time, they would survive to discharge. No single factor, such as a person's age, would be taken in isolation as a determining factor, and decisions would not be made arbitrarily or in such a way as to result in unfair discrimination. We were very conscious of age, and that's why we use the term frailty, because frailty can differ from different age group to different age group, obviously. But we were very conscious that some of the guidelines that started to appear more or less stated that anybody over the age of 80 would not be admitted to intensive care and would not receive the kind of treatment that we were discussing. Where it was decided that the provision of intensive care treatment is not beneficial or possible in the light of the circumstances, patients would be provided with other available potentially beneficial forms of treatment. With example, in COVID-19, respiratory supports may still be given, non-invasive ventilation, oxygen, and where the patient is unlikely to recover, appropriate palliative care or end-of-life care should be provided. But we found it very crucial that withholding critical care doesn't mean the patient would no longer be cared for. And that had to be demonstrated very clearly to the patients, that just because they weren't admitted to intensive care didn't mean that they would get a poorer treatment. We also had to think of the staff, that making these kind of decisions, both clinically and psychologically, were very challenging. And those are responsible for assessing patients and making triage decisions must have proper support in allocating scarce life-saving resources. Data from other countries has documented the physical, psychological, emotional, and moral burdens that these choices have placed on those working in intensive care. And a lot of health systems set up support systems of counseling, etc., that healthcare care professionals could avail of, particularly those who are finding it very difficult to make decisions. So that was really on intensive care. I now want to look at the vaccines, because that was an important discussion afterwards when the vaccines became available. These were the front runners, which you're all familiar with: the AstraZeneca, Moderna, Pfizer, Sputnik. We don't hear much about Sputnik anymore, and others gradually coming into the market, such as Janssen. I gather from evidence that there's about 300 vaccines, potential vaccines for COVID-19, and that's quite an interesting development as well. And so basically, who should get it? Who should get the vaccine, and in what order? The European Commission coordinated central procurement process on behalf of member states. That's why all vaccines were centrally ordered by the European Commission and then distributed proportionately. The Irish government decided to start vaccinating those most likely to die if they contracted COVID-19, prioritizing the most vulnerable frontline health workers and care workers, and that is ethically sound. But then the question is, who should come next? People at a high risk of infection, people such as teachers, transport workers, should they be the next in front of the queue? But should account be taken of those who are more at risk of infectious disease because of discrimination or social inequalities? One group that was particularly worrying were the homeless. When in that they live in conditions where they weren't socially distancing, etc., and therefore should they be a priority group as well, and those who have been discriminated against in society. However, it also became an issue of international justice. As you know, a pandemic is by its nature global and will not be defeated anywhere until it is defeated everywhere. There's a very interesting article in the BMJ entitled COVID-19, Many Poor Countries Will See Almost No Vaccine Next Year. This is 2021. at least 90% of people in 67 low-income countries stand little chance of getting vaccinated against COVID-19 in 2021, because wealthy nations have reserved more than they need, and developers will not share the intellectual property. And that came from the People's Vaccine Alliance group. So unless something actually changes dramatically, billions of people around the world will not receive a safe and effective vaccine for COVID-19 for years to come. Rich countries with only 14% of the world's population have bought up 53% of the 8 most effective vaccines. And if you look at any of the statistics from Johns Hopkins' site, which I'm sure some of you access from time to time, just start looking through the African countries, and you'll see, 2% of the population vaccinated, 3% of the population vaccinated. So very small percentages being done, and similarly in some Asian countries as well, and poorer countries as well, very small numbers being vaccinated at the moment. So what they set up was COVAX, which was global solidarity, and this was set up by the WHO, the European Commission, and France. The aim was providing innovative and equitable access to COVID diagnostics, treatments, and vaccines. All participant countries, regardless of income levels, will have equal access to these vaccines once they are developed. The initial aim was to have 2 billion doses available by the end of 2021, which would see enough to protect the high risk and vulnerable people, as well as frontline healthcare workers. So even once again, we were only prioritizing the high risk and the vulnerable for a large percentage of the world's population. What was very interesting, and I'm sure some of you will be familiar with, are the challenge studies going on in the UK at the moment, particularly with the COVID vaccine. What they are arguing, really, the advantages of it is cost and time effective, as they will allow for a quick differentiation between promising and poor vaccine candidates, require small numbers of participants, so expose fewer people to risk, which would mean that we'd cut out the phase 3 studies, phase 2 and phase 3 studies. But the question really is, does intentional exposure of healthy individuals to disease violate the fundamental ethical principle of do not harm your patient? And Helsinki is quite clear on that as well, the Helsinki Declaration. Is this especially relevant in COVID-19, given the lack of treatments? Currently, there have been some very interesting treatments emerging on how to treat COVID, but there is actually fundamentally no cure at the moment for it. So you're going to expose people to a disease or a virus, which we have no cure for at the moment. Is it enough that people freely volunteer? And who determines whether risks and benefits are appropriately balanced? Who decides that? Should they be paid? We know that in the UK, they're going to get 4,500 sterling if they participate in it. And another challenge really is informed consent. How can somebody consent to something they know nothing about, or they don't know how it's going to develop? So these became quite crucial elements in it. The WHO also issued a report providing guidelines for how such trials should be designed, but the community was undecided over whether they should ethically proceed. So it has become quite an interesting ethical issue, and therefore we await to see the reports coming out of the UK on the challenge studies that have gone on there. Vaccination passports has become a bit of an ethical issue as well, because of the social consequences of not having a vaccine or having a vaccine. Will a certificate of vaccination be demanded as a passport to gain freedom to mix socially? Businesses may see certificate as means to safely allow passengers onto their aircraft or not. Also to reopen restaurants. Some of the, I was away during the summer in Portugal, and before you could go into a restaurant, you had to produce your vaccination passport, which they then scanned, etc., and took your contact details. And when you were boarding ships or aircraft, it became sort of mandatory that you had to start producing this documentation. This raises the danger of discrimination against those who have not been vaccinated and could create pressure on people to be vaccinated to actually keep their jobs. And we noticed that certain people have been dismissed. I just read an article the other day that 3 members of the Swiss Guard in the Vatican have been fired because they refused to be vaccinated. So they're going back to Switzerland, obviously. Therefore, vaccine passports started to become the norm. And in 17th of March of this year, the European Commission published a proposal for digital green certificate to facilitate free movement within the European Union. And it would act of proof that the person had been vaccinated or had received a negative test or has recovered from COVID. So that was the passport that they were actually issuing. And most of us in Ireland who were vaccinated, etc., have received these passports as well. But this has serious challenges really to it. That the fundamental rights and freedoms are restricted to prevent the spread of infectious diseases. That's important. But they must have a legitimate aim, proportionate and at least restrictive measures. If a vaccinated person has a vastly reduced risk of getting or transmitting the virus, does it remain proportionate to restrict their rights and civil liberties? So if you're vaccinated, should some of these restrictions be actually withdrawn from you? There's also the potential of discrimination, that people who actually cannot be vaccinated because of medical risks, etc., or their responsiveness is suboptimal. Are vaccine passports a backdoor to mandatory vaccination? Another statistic came out was that there are about 1 billion people in the world who don't have any documentation. They don't have birth certificates, they don't have residency certificates, etc. So how are we actually going to deal with those people with regards to vaccination passports? Equity really is marginalized groups are disproportionately affected and higher vaccine hesitancy amongst those groups. Lower levels of media, health literacy, vulnerability to misinformation, less access to health services, those in rural areas or living in areas with less well-resourced health services could reinforce structural inequalities, job offers contingent on vaccine status. And we've all heard the misinformation that has gone out. Actually, the WHO on one of their websites has a whole list of all the potential misinformation that was delivered. And you still have it today, actually, where you have people actually saying, you know, that if you get vaccinated, etc., the government will be able to track you, etc., or we fundamentally change your genes, etc. You still hear that kind of stuff coming out, and it's quite amazing with all the information that has come out. Privacy also became an increasing ethical problem. Increased surveillance, digital identities for all, containing sensitive personal health data. And those were some of the apps that people had problems with. As I've said, more than 1 billion people aren't able to prove their identity because they lack passports, birth certificates, driver's license, or national identity cards. Also, one of the questions is who will have the power to view these passports? Which will only the public or the civil servants be allowed to view them, or will private entities be also allowed to view them as well? What started to emerge was a term, infodemic, started to emerge. While digital information and communication technologies have facilitated an immediate sharing of important pandemic-related information, they also have enabled the term infodemic. Vaccinating a large proportion of the Irish population will be pivotal to establishing national immunity. Most estimates fall between 60 and 80% of the population, though how many people will need to be vaccinated to reach that point is still unclear and depends really on the efficacy of the vaccine. Vaccine hesitancy, as I've said, and misinformation represents a significant challenge in this regard. Public resistance to vaccination due to factors such as fear, media coverage, incorrect information could negatively impact upon achieving herd immunity. And this underlines the importance of trust, transparency, and the availability and accessibility of accurate information from trusted resources or sources, etc. And I suppose that has become very important as well with some of the websites developments. But should vaccinations become mandatory? Realizing herd immunity is a collective enterprise and gives rise to tensions between the individual and collective responsibilities and rights. The magnitude of the public good needs to be balanced against the countervailing rights of individuals, as well as other public goods such as public trust. Therefore, the rights of autonomy, respect for autonomy and bodily integrity, and people's decision-making process in that. If we're going to make them, we need to demonstrate that they are proportionate, and they must be proportionate in this way. They must have a legitimate aim. Measure must be able to achieve that aim, and measure must be necessary to achieve the objective. Measures must be reasonable, considered, and considering the competing interests of different groups. One of the big issues was the impact on actual practice and on training. And I just want to go through this with you. And what I did was, these were some of the guidelines which were started to develop, particularly around surgery. During the lockdown, elective surgery should be postponed indefinitely. Life and limb-threatening surgery should be performed only where outcomes are dependent on timely interventions. Patients who have been triaged as unsuitable for ventilation should not normally have a surgical procedure performed. Also, there was a lot of area around PPE and staff training, etc., and the buddy systems and checklists, and all of us would be quite familiar with some of those that went on. In the operating theatre, this became important in one of the guidelines, that you should have a dedicated operating theatre should be assigned for treating COVID patients. The number of staff in the operating theatre should be minimized. Procedures should be performed by senior and experienced staff to minimize procedure time. Now, that has a significant impact on training, particularly in surgery, and we'll come to that in a moment, actually. Also, there was a move to more telemedicine, to trying to curtail patients' visits to hospitals post-operatively checkups, and therefore alternative standards started to be emerged. But as most of you will be aware, that telemedicine has started to create some quite interesting ethical dilemmas, and particularly legal dilemmas as well. One of the issues that most of us like which occurred during the pandemic was repeat prescriptions. You no longer had to go to your GP to get your repeat prescription. Your GP could actually send it via email to your nominated pharmacy. But one of the issues that has arisen with that is that the prescription should be signed, physically signed by the GP. And so I personally hope that we'll be able to get around that in the future and stop us having to travel to our GPs, etc. So what I've got here is the experience of about 3 categories. And this is people involved in pulmonary procedures. Procedures that generated aerosols were more or less stopped. Testing for lung volume, but some limited pulmonary function could be carried out, but with significant protection for staff and patients. And we know that the staff were heavily masked up, etc., with PPE. The numbers were curtailed significantly. Tests done with 60 to 90 minutes between patients for cleaning. So you could just see the amount of time or the minimum number of patients that would actually see. Routine pulmonary function was curtailed unless the lab had air exchange equipment, and evidently most of them don't. And tests carried out were limited and only done for specific reasons, pre-operative, or patients very ill, maybe needing surgery for cancer. Equipment would then have to be sterilized, and generally once-off use equipment was the norm. Say the electrodes were discarded as well. Outpatients were carried out but curtailed to new patients, and review of return was essentially done by telephone or online. So for chronic, non-acute medical and surgical problems, there's been a significant backlog generated over 18 months, which is very worrisome and will be addressed and will have to be addressed in some way. This is endoscopy surgery. And we know that at the outbreak, a significant number of senior staff and radiology staff were actually developed COVID, and that reduced the surgical procedures in these cases. And what happened really was in some hospitals that only urgent cases were done, and they were determined by various guidelines, and cases had to be individually put before the multidisciplinary teams. Urgent cases were performed in line with RCSI guidelines and recommendations, which were cases that were confirmed cancer cases that were time sensitive, suspected cancer cases, and acute surgical emergencies. In oncology, there was also questions that started to arise. maintenance of certain drugs were stopped, and with particularly patients with low-grade lymphemia, and the risk of death from COVID-19 outweighed the 20% benefit of a 2-year delay. Hesitant to start certain forms of chemotherapy, low-grade treatments, etc., started to emerge. A lot of status colorectal patients on maintenance chemo with stable disease were given a 3-month holiday from their chemotherapy. Certain drugs, which were for immunity drugs, which were given every 2 weeks, were now given once a month, and 3-weekly drugs were given every 6 weeks, but at a higher dosage. Delayed diagnosis of colorectal cancer with symptoms dating back 18 months only now beginning to emerge. And they really emerging as a stage 4 of the disease. In Ireland, the HSE had a hack, and that delayed all PET scans, etc., and treatment of lung cancer. As screening ramps up, we will most probably see an avalanche of new cancers starting to emerge as well. This is an article from one of the journals, and what they were looking really at was orthopaedic surgery. And this is the UK. In 2020, about 60,000 primary hip and about 53,000 knee primary joint replacement procedures were done. This represented 57 and 49% reduction of the usual numbers of 2019. So quite a serious reduction on hip replacements and on knee joint replacements. Even with a 10% increase in capacity, it takes 5 years to recover to the pre-pandemic levels. That is coming out of the NHS. The devastating and disabling effects that joint pathology can have on individuals and the distress this can cause to the immediate family and friends is quite significant. Patients report an increase of their symptoms. They also sense that there will be an increased burden that such patients will likely place on the community and the care services, which are heavily understaffed. One of the real dangers is that some will have a suboptimal result because of the delay in their surgery, and that is particularly worrying as well. What is also worrying really is the impact on training, particularly in orthopedics, and I refer to orthopedics here. It is an area of the acquisition of surgical skills gained in the operating theatre, and there's been a very real impact, and the impact for large numbers of trainees has been devastating. There's been a 15% drop in trauma cases. Elective procedures, over 250,000 in the UK, were dropped, and therefore 58% of training opportunities were actually lost. In individual cases, individual trainees lost about 260 cases, which they were not able to participate in. There are different solutions, such as the extension of their training, etc. However, that has a significant financial implications, which people need to address. I'm going to conclude now. I have a case study, but I see there are a number of questions coming up in the chats. So perhaps we'll have a look at those now.
Professor Smith, thank you very much. That was great. There are, as a reminder, the Q&A box is open. I'm gonna take the chair prerogative here and ask you the first question. Earlier on in one of your slides, you'd said that the curtailment of individual rights for the benefit of collective benefit had a number of requirements, and the first requirement was that the measure or the curtailment must be reasonable. How within the ethics community do you define reasonableness, and who defines reasonableness?
Well, I suppose it's linked very closely to proportionality. You try to ascertain really what is the historically what has been the reasonable position taken, where have people taken different positions like this, etc. And you would then be able to determine that this is a reasonable position to take, which A, the public can understand, and B, the public will accept.
So to push on that a little bit, so the public understanding and public acceptability must sort of by definition be different depending on where that decision is being made. So if I'm understanding it, the reasonableness would differ depending on who the public that is being addressed is.
Yeah, it can be, and we've noticed that the way that the vaccines were distributed in certain countries, the politicians got it first, and I don't think that that was reasonable at all. The reasonableness would have been the most vulnerable people should have been access to it, and therefore frontline healthcare care workers, like any reason, would demonstrate that we look at the most vulnerable in our society first of all, and the politicians are definitely not the most vulnerable of people. But yeah, so we'd look at things in that way.
Thank you. There's a question in the Q&A from Mohammed Amjad Chowdhury. Mohammed asks, what are the recommendations for aerosol generating procedures like bronchoscopy for foreign bodies in children specifically?
Well, at the moment, they start in Ireland. I know they're starting to occur again. But the PPE is being extensively used. I was in a private hospital recently in Dublin, and the PPE, the staff were heavily masked, etc., and gowned, etc., doing anything where there was a potential aerosol leakage or potential aerosol coming from the particular patient. So I suppose really one of the crucial issues has been around training the staff and keeping them aware of the necessity of using PPE in these circumstances. But I do know that in Ireland we've started to get back on track, and hopefully we'll be fully back on track within the next couple of months, where all these procedures will be normally done, but still with quite clear focus on PPE. Like you still, still in a lot of the hospitals at the moment in Ireland, you still can't visit. And if you're in the hospital for any type of procedure or any type of business arrangement, you have to fill in a form, etc., and you've got to be masked, etc. And at one meeting I was at, we were also gloved. For some reason, we were gloved as well. But so people are taking it very seriously. But I think that the hospitals and healthcare facilities will continue to do that for quite a significant amount of time. But hopefully we'll get back to normal. But in other countries around the world where this isn't available, it's particularly challenging for them as well, as I could imagine Mohammed is finding.
There's one comment in the chat from President O'Connell who says, thanks you for the interesting presentation, and says, no doubt we will see many late diagnoses and adverse outcomes in the coming months as a result of deferred investigations. I suspect you would agree with that.
Yeah, yeah. Just anecdotally talking to people around, particularly in oncology, that seemed to be a particular worry for them as well. I think also one of the factors that started to emerge was that during the lockdown, people who were ill or who felt ill didn't access healthcare facilities. They either through fear or they didn't want to be a burden on the healthcare facility. They had certain symptoms which they tried to self-medicate with themselves, but in fact they should have accessed the health facilities so as a proper diagnosis could be made. So I think there's going to be a delay there. There will also be evidently there will be a delay in pulmonary care as well. And then I gave you the statistics from the UK on orthopaedics. You know, significant delays in people getting a hip and knee replacement operations in the next 5 years, which will have a significant impact on them and on their lives, and fundamentally on their families and the care services that are available.
Thank you, Professor. There's another question in the Q&A, but I wonder before I get to that, do you think we have enough time to go through your case presentation? Because that might be quite interesting.
Certainly we have, if you'd like.
I'd love that. That'd be great.
Right, I have a short case presentation for you here. And this is around priority settings in an intensive care unit. A regional hospital is a major trauma center with a large emergency department and intensive care unit. During the outbreak of COVID-19, the ICU was filled to capacity with patients suffering from life-threatening medical conditions, including severe respiratory problems. The emergency department calls the ICU to seek to admit Mr. M, who has been brought to the emergency room with a severe but potentially reversible brain injury from a cycling accident. One alternative is to move one of the current ICU patients to a medical unit in order to make room for Mr. M. However, the ICU staff reports that all of their patients need ventilatory support, and there are no other ventilated beds available in the hospital. Another alternative is to send Mr. M to another unit in another hospital. However, given his injuries, it is clear that it would overtax the clinical capabilities of the healthcare staff who are not trained in critical care and who are struggling to care for other patients as well. The final alternative is to transfer Mr. M to another healthcare facility. However, COVID-19 pandemic has overwhelmed all hospitals in the region, and there are no available ICU beds anywhere. You now hear that an ICU patient has passed away and there is a bed available for Mr. M. Just as his transfer is about to be made, the intensive care nurse named Miss A is admitted with severe breathing difficulties. It is determined that she has been infected with COVID-19, which she might have contracted while caring for patients in the hospital. She needs immediate ventilatory support, which is only available in an intensive care bed designated now, but unoccupied by Mr. M. It also comes to light that Mr. M has aging parents at home who rely on him for help and activities with daily living. Mrs. A is a mother of 3 children and a long-standing employee of the hospital and is well respected by her peers within the hospital unit. So the questions, I suppose, which we'd need to address in a case like this are: what are the most important considerations in this scenario? Which ones are the most relevant? Are there any considerations that you might find significant in the last piece of evidence about their social responsibilities? Do these personal details about the 2 patients' life affect your perspective on the case? And fundamentally, who should get the ICU bed, Mr. M or Mrs. A? And who should make this decision? And how should these decisions be made?
I guess we don't expect an easy case presentation from an ethicist. If the participants here want to give some thoughts, I think probably the easiest way to do this, either you can raise your hand and we can give you speaking abilities, or if you want to put some thoughts to Professor Smith's ethical case discussion into the chat, I can read those out to him as well. It's like you've got people stumped here. I'm going to go out on a limb here and talk about the social details you gave at the very end of Mr. M's parents and Mrs. A, having been at the hospital for a long time. Is there any consideration to be made for Ms. A, and her potential future, if she survives this, future ability to care for future patients in this scenario?
Well, we hope that, I suppose, if she's ventilated and if she recovers from, we presume she has COVID, that if she recovers from it and makes a good recovery, she'll return to work. In that she's most probably a very dedicated practitioner as a nurse in the intensive care unit. So that would be a factor which would start to occur there.
I'm trying to keep up here with Lorna Murphy says that the healthcare staff are at a higher priority as they are needed in the healthcare facility, and as a result, I think Miss A should get the bed. Mm-hmm. Eric O'Flynn asks, is the concept of frailty previously mentioned one of the most relevant factors?
I think it is a very relevant factor, because depending on the frailty of a person is their responsiveness to the treatment that you're going to give them. And I think that becomes an important factor. And that's why we deliberately used frailty instead of age. Like you could have somebody, say, in their 40s because of a number of comorbidities who would be considered very frail and maybe would not be able to withstand mechanical ventilation, etc. So frailty is quite an important component, I think, in any decision making like this.
So there are two then related comments in the chat here from Marina Lupari and Khalid Ahmed, who both say the decision should be made by the medical team and the priority should go to the one who is most likely to survive.
Yeah, yeah. But it's very difficult to ascertain whether it's Mr. M or Mrs. A are going, or Miss A are going to survive. You know, that's generally a clinical decision, and it might not be a very accurate clinical decision. But yeah, I can understand why they're using that as an important element in the decision-making process. What about, I suppose one of the questions that you'd put is, have we asked Mr. M and Mrs. A what they want?
Would it change things if they both wanted ITU care?
Well, yeah, we'd be back to the same problem again. And it might be easier if one of them said, no, I don't want it, you know.
There's a suggestion here also that we review current ITU patients. Should other patients within the ITU be taken into consideration in these decisions?
Yeah, I suppose so. Yeah, if you can, and that's normally, I suppose, the case in intensive care units, is that you look at patients who can possibly be discharged to a step-down facility within the hospital unit, not as intensive as intensive care, or sometimes they call it a high dependency unit, etc. And that would be sort of a continual assessment that goes on in intensive care. I know in some of the acute hospitals in Dublin, Friday is quite an important day for that, particularly if we're having a long weekend and we have potential road accidents coming in. So that I think would be normal. You'd not only look at the COVID patients, but you'd look at other patients who are intensive care as well.
Let me turn to a question here. I'm just going to read it out to you. Is it ethical that family doctors advised/told patients and are still advising their patients that they should go to emergency departments as they, i.e. the GPs, were not willing to see patients with respiratory complaints?
No, I think that's a bit of a cop-out, really, because the respiratory complaint might be asthma, for instance. And during the crisis, one of the problems was the emergency departments were heavily loaded. You had people coming in ambulances who were obviously extremely ill and needed respiratory care. But yeah, I suppose what GPs did is they had telephone conferences or they had online conferences, and they were able to make a reasonable diagnosis. But just to demand that people with respiratory problems immediately go to an accident and emergency, I think is a slight cop-out, really. And people should be able to make decisions. These are highly trained people, GPs, so they should know from their patients' records what their actual respiratory problems are.
Well, Professor Smith, thank you very much. I think we're done. We're out of the questions here. So thank you. This was fascinating. I mean, the COVID pandemic has unearthed a whole, as you reviewed here, a whole host of ethical considerations on the individual level, whether we give the ICU bed to Mr. M or to Ms. A, to the population level, inequities in access and questions of vaccine hesitancy and vaccine mandates and vaccine passports. So I really appreciate your time to speak with us. To the attendees, again, we do these every month. Next month will be on the 3rd of November at 2 p.m. Dublin time. We will have John Kachimba, who is Senior Medical Superintendent and Consultant Urological Surgeon at Livingstone Central Hospital in Livingstone, Zambia. He will be speaking to us. If you want to see a video of Professor Smith's presentation, it'll be up on our YouTube channel sometime within the next few days. Go onto YouTube, search for RCSI Institute of Global Surgery, and you'll be able to find it. Again, Professor Smith, thank you so much.
Yeah, thank you very much. I really appreciated this opportunity. Gave me an opportunity really to present a lot of the work that the working committees did for the Department of Health. Under very stressful times, we had to move very, very quickly. So I really do appreciate the opportunity. Thank you very much.